The inhaled anesthetics have effects on muscles. In fact, the inhaled anesthetics affect every part of our body, but the neuromuscular effect is particularly important because of its need for surgical procedures and for instrumentation of the airway. How do the inhaled anesthetics produce muscle relaxation? What is it that they do? Can anyone tell us? What do they do? Can you get an effect of the inhaled anesthetics without ever an effect on the neuromuscular junction? Yeah, you can. So where are the inhaled anesthetics acting to produce that effect?
Central nervous system.
In the central nervous system. So they're acting at higher centers to produce relaxation or an absence of an input that produces contraction. And add to this the direct effect of these anesthetics on neuromuscular transmission. We know that they do have effects on neurotransmission from studies such as those conducted by Jim Caldwell. So we look at the percent of fade at a tetanic stimulation. And we see that as we increase anesthetic dose, this is MAC of desflurane, but it could just as well be MAC of isoflurane or MAC of sevoflurane. We see that there is an increasing fade, and that the presence of nitrous oxide doesn't alter that. Nitrous oxide is not a muscle relaxant. Only the potent inhaled anesthetics give us muscle relaxation. No effect. The effect of the potent inhaled agents, both the combined central effect and the effect on the neuromuscular junction itself, is sufficient to produce relaxation for surgery without any use of neuromuscular blocking drugs. Let's see that.
More big breaths for me, okay?
I'm going to give 2 cc's of fentanyl.
Okay.
And how much propofol did you want to have?
200, please.
Okay.
Okay, thank you.
Ms. Washington, you're going to be going to sleep in just a few seconds.
Okay, the heart rate increasing.
And you now have apnea.
Apnea.
Okay.
And no lid reflex.
Okay.
Just another second.
So you can do this just with the relaxation produced by propofol, right?
Yes.
All right.
See, it's easy to open her mouth.
Okay.
And good visualization.
That wasn't very hard.
Not very hard at all.
So it can be done without a muscle relaxant.
Very easily.
Lots of things can be done without a muscle relaxant.
What we've tried to accomplish here is to use desflurane only, no muscle relaxant, to see if we can achieve enough muscle relaxation where the surgeons could retract the and open up the peritoneum and be able to have their surgical field the way that they want it.
So how did you induce anesthesia?
What we used was propofol and fentanyl only, no muscle relaxant. We intubated her without any problem, and then we are maintaining our desflurane concentration at an end tidal of 9%.
9%?
Yes.
Is that compatible with good cardiovascular dynamics?
Well, as you can see, we have a pressure of 105/76 and a heart rate of 66. So apparently it is.
What about the relaxation?
The relaxation actually is superb. They have said that the relaxation is working fine from a surgical standpoint, so we're very happy with the way things are turning out.
And that's without any
That is no muscle relaxant whatsoever.
Very good. Thank you. So if you need to achieve muscle relaxation and you don't want to give a neuromuscular blocking drug, perhaps with myasthenia gravis, one way to do it is to use a potent inhaled agent. at a deep level of anesthesia. On the other hand, you may not want to use a deep level of anesthesia for reasons of rapidity of recovery or depression of the circulation. This sort of evidence would suggest that you would enhance the effect of neuromuscular blocking drugs, and in fact, that is the case. Neuromuscular blocking drugs have an enhanced effect relative to an intravenous approach to anesthesia, such as a propofol anesthetic. And that's shown in this slide, which indicates the minutes of achievement of paralysis with various neuromuscular blocking drugs with various inhaled anesthetics, desflurane, isoflurane, and sevoflurane, compared to propofol. And in several of these cases, you see that the little symbol here indicates that there's a difference between propofol and one or more of the potent inhaled agents in terms of how long the neuromuscular blocking drugs acted. You can also show this in terms of the dose that's required to achieve a certain level of neuromuscular blockade. Now, the effect of the potent agents, as you might anticipate from the previous slides that we've done, are related to anesthetic concentration. They're also related to the age of the patient. So we look at the age-adjusted MAC of sevoflurane and how it determines the infusion rate of mivacurium that's required to achieve paralysis. We see that the higher the MAC multiple of sevoflurane, the lower the infusion rate that's required. And that's true in adults and it's true in children, but more is required in children. Why is more required in children?
They have a greater volume of distribution.
Okay, they've got a greater volume of distribution, and that would be an appropriate answer if we were talking about a bolus of mivacurium. Indeed, the volume of distribution that would have to be occupied would have to be greater. But we're talking about steady state here because we're talking about an infusion of mivacurium. So there must be another answer in addition. And we had two people wanted to answer. Tracy?
They have higher plasma cholinesterase levels.
And that's important to mivacurium, isn't it? So they just dispose of the mivacurium faster than do adults who have a lower concentration of cholinesterase, pseudocholinesterase, in the blood. Now, we've also discussed the need to maintain one twitch. And the need to maintain one twitch is because in the absence of maintaining one twitch, if you go beyond that, you may not be able to produce recovery from paralysis. And that's very important to us. It's important, if we can, to maintain even more than one twitch. Why is that? Why might you want to maintain 2 twitches or 3 twitches?
Decrease the neostigmine that you need to give at the end.
Yeah, and therefore perhaps decrease the incidence of postoperative nausea and vomiting. How might the enhancement of the effect of muscle relaxants increase safety from anesthesia or from the use of the neuromuscular blocking drugs? How might we need to?
Well, as you turn down the agent at the end of the case, you should get a heightened response.
You should get a heightened response, and that's been shown. Been shown by Peter Wright in a study comparing desflurane and isoflurane. But the more important thing is not the difference between these two agents, but the similarity in the effect of turning down the anesthetic concentration. This is a study in which anesthesia was developed and held at 1 1/4 MAC, 1 1/4 MAC, and an infusion of vecuronium was begun and continued to sustain a paralysis that was, I believe, about a 90% paralysis. So we've got, in fact, 10 or 20% twitch of the controlled twitch down here. So the vecuronium is coming in, sustaining a constant level of vecuronium. We've got the isoflurane or the desflurane at 1 1/4 MAC, and now we turn down the desflurane and the isoflurane. We go down to 0.75 MAC. Continue the vecuronium, and the blood levels were measured, so there wasn't any change in the blood levels of vecuronium. And we get reversal of the depression of the twitch. Go to an even lower level, 1/4 of a MAC with nitrous, 1/4 of a MAC, and you get a further reversal of the effect of the muscle relaxant. Again, the muscle relaxant level hasn't changed. What's changed is the anesthetic level. So we have increased the safety by reversing some of the effect of the muscle relaxant. And that's what happens when you eliminate the anesthetic on recovery from anesthesia. So it enhances the safety the delivery of anesthesia. And we can show that in one of the OR scenes. Michael, we're infusing vecuronium at what rate?
It's 0.3 mics per kilo per minute, which is about 1.5 milligrams an hour.
That's an awfully low dose. How can we give that lower dose and get only one twitch out of a train of 4?
Well, our desflurane concentration still remains high.
How high is it?
It's at end tidal is at 7.3.
And that's what MAC?
That's
multiple?
about 1.2 MAC.
So the desflurane is doing what to the vecuronium?
It's enhancing the action of vecuronium.
Normally you'd expect to give what? How much more vecuronium than that?
Probably 1 to 2 mics per kilo per minute in the infusion rate.
So that's 3 to 6 times as much. That is, you've achieved a great economy by giving the vecuronium in the presence of a substantial concentration of desflurane.
Yes.
We also see that there's fade in the neuromuscular response to 50 hertz tetanic stimulation. What's going to happen when we turn down the desflurane?
I believe what should happen when we turn the desflurane down, we should lose that enhancement that we're gaining from using it, and we're going to probably gain a number of, at least a twitch back, and probably height of twitch too.
And perhaps some of the fade on tetanic stimulation will disappear.
Sure.
Does that add to the safety of this anesthesia we're delivering?
I believe it does, probably more when we go to discontinue the anesthetic, probably more than any other time, because we want the patient to be have all their muscular function back and ready to control their own airway.
Right, so we can eliminate some of the relaxant effect just by eliminating the inhaled anesthetic. So why don't you turn the desflurane down now?
Okay.
We've eliminated the desflurane for 15 minutes now. What's happened? What's changed?
We have an increase in our train of 4, and from that one twitch that we had before when we had the desflurane at the higher concentrations, we've decreased it to an end tidal of about 1.8, 1.9, and now we have 4 twitches in a train of 4. And our tetany has also increased. We still have fade, but we have an increase in our tetany response.
That's been pretty obvious, isn't it?
Very obvious.
And that's despite the fact that we have continued the vecuronium infusion.
At the same rate.
So the vecuronium blood level probably hasn't changed at all.
Correct.
Elimination of desflurane then allows recovery to occur, doesn't it?
It does.
It's been 30 minutes since we turned off the desflurane, and we've noticed what in terms of a progression of the return of neuromuscular function?
We continue to get an increase in neuromuscular function, as evidenced by the increase in the train of 4, increase in the sustained tetany. We saw a little bit of fade at the end, but our sustained tetany was much more than when we looked at it 15 minutes ago.
And what about the train of 4? What changes did you notice there?
We did have a 4 train of 4, but we saw increased twitch height on all 4 twitches.
So not only do we have all 4, but they're bigger.
Correct.
And that's despite what?
That's despite keeping the vecuronium infusion at a continuous level.
So the level of desflurane really makes a big difference in the response to vecuronium.
Absolutely.
And probably to all non-depolarizing muscle relaxants. Do you think this is unique to desflurane?
No.
Probably occurs with all potent inhaled anesthetics, doesn't it?
Correct.
Which is a nice safety feature of potent inhaled anesthetics.
Mm-hmm.
So this has implications for surgical demand for more relaxation. What can we do? Surgeon says, I want more relaxation. How are you going to deal with that? You give more relaxant, or you can increase your concentration of your potent inhaled agent. It is a safety factor, as we've already discussed. It decreases the need for reversal, and it decreases the potential for postoperative nausea and vomiting. It has implications for the patient who has renal or hepatic failure. We don't need as much relaxant because we can achieve relaxation with the use of potent inhaled agents, either alone or with small doses of neuromuscular blocking drugs. There's a special disease that may also be influenced by this capacity of potent inhaled agents to produce neuromuscular blockade by itself, and that, of course, is myasthenia gravis. If you were to anesthetize a patient with myasthenia gravis, how might you do it? What would you do? What would you do?
Well, I would probably induce as usual, and then I would use a neuromuscular blocker, but I'd titrate it to effect. For intubation dose says you'd use a lower than normal dose, and then for my sustaining relaxation during the case, I'd titrate it to effect.
So you would be very careful in the amount of neuromuscular blocking.
Yes,
right?
I'd expect to use lower in a myasthenia gravis patient.
Okay. Would anyone do it differently? Everybody likes that approach. You like that approach? Mm-hmm. Okay. You like that approach too?
That is a very plausible way of doing it. You could also just use a potent inhalation agent, such as isoflurane or desflurane or sevoflurane, and just use it at a higher MAC level.
Okay. I think that's right. And many people would say, just use the inhaled anesthetic. Just use sevoflurane. You can induce the anesthesia with sevoflurane. You don't have to give anything else. You don't have to give any neuromuscular blocking drugs. And you can achieve all the relaxation you need. In fact, the patient with myasthenia gravis needs very little more than sevoflurane or desflurane or isoflurane. Why would it be important or useful to use the potent inhaled agents that are less soluble in that patient? Well, you're going to get impairment of neuromuscular function with the inhaled agent. And at the end of anesthesia, you want to get rid of that. You want to get back to normal or as near normal function as you possibly can, as quickly as you can. Malignant hyperthermia, another problem with the neuromuscular junction. What's malignant hyperthermia? What is it? Tracy, what is it?
It's a hereditary disorder characterized by a hypermetabolic state. Basically, there's a defect in the ryanodine receptor, and there's an increase in calcium.
Boy, that's very good. It's more than I expected. That's terrific. Yes. All right. And so what? How does that apply to anesthesia?
Well, you're not going to use inhalational agents that might precipitate or trigger the malignant hyperthermia. And almost all inhalational agents do, except for nitrous oxide.
All? And are they all equally effective in triggering?
I'm not sure about that. I think there's some that are more effective, but the fact is you're not going to use inhalational agents if somebody has malignant hyperthermia. So.
Which do you worry about most? Which one do you worry about most?
Halothane.
Halothane is the one you worry about most. And here's some of the evidence for that. This is from the MH registry. It's the median minutes to the onset of malignant hyperthermia in all of the cases that they have. And it is definitely shorter with halothane than it is with either isoflurane or desflurane. And there's no significant difference between these two. One of the reasons for that, or perhaps one of the reasons for that, is that the number of cases with desflurane is very limited. There are far more with isoflurane, obviously because isoflurane has a far longer history of use than does desflurane. Now, if you're going to have a problem, if you're going to have a patient who is suspected to be predisposed to malignant hyperthermia, you're going to have to deal with that. And let us illustrate how you might deal with it.
Well, Mike, I see that you have your dantrium out and a syringe of succinylcholine. You must be preparing for a malignant hyperthermia susceptible patient.
Well, I think we probably can go ahead and get rid of the succinylcholine.
Well, I hope you weren't going to use those together.
No, not at all.
All right, great. I think you have some plans to prepare your gas machine for this patient.
Yes, as you can see, we have a high flow of oxygen going through, and the purpose of that is to flush out the system. We're going to do a couple other things in addition to that. We are going to remove our vaporizers, and as you can see, that's easy to accomplish on this particular machine. Now we're going to remove our soda lime and replace that with fresh soda lime. Here I am removing the bellows. I'm now removing the anesthesia circuit and the ventilation bag, replacing the anesthetic circuit. That is And replacing the bellows, I'm actuating manual ventilation. And initiating mechanical ventilation.
Mike, was it necessary for you to remove the vaporizers?
No, it wasn't necessary to remove the vaporizers. We decided to do this as an extra precautionary measure because it's so simple to do on this machine.
You've also done a leak check. What was the reason for that?
We just wanted to make sure that there was no leaks in our system.
And this actuating mechanical ventilation with the fresh gas flow at 12 liters a minute, that seemed to be the last thing that you were doing. And the purpose of that?
The purpose of that is to make sure that we get good gas flow through the canister.
The neuromuscular effects of inhaled anesthetics are considerable, and they are of enormous clinical importance. For some perhaps esoteric things like myasthenia gravis and malignant hyperthermia, but they're much more important to the everyday administration of anesthesia. And the fact that the potent inhaled anesthetics enhance the effect of muscle relaxants and can cause relaxation by themselves is of enormous clinical help to us.